afternoon. I'm Dr. Jana Martin, and I'm delighted that you're able to join us virtually today for our next webinar. I'm pleased to introduce you to the Trust's new CEO, Dr. John Davison. Dr. Davison comes to us from the Defense Health Agency and brings a wealth of experience with a proven track record of leading complex organizations. He received his PhD in clinical psychology, as well as his MBA degree from Auburn University. We look forward to the Trust continuing to thrive under Dr. Davison's leadership. I'll now turn it over to Dr. Davison so he can share a few words with you, and then we'll continue with the webinar.
Thank you, Jana, for the introduction. I appreciate the opportunity to virtually meet so many of our policyholders during today's roundtable. I'm thrilled to join the Trust as new CEO, and I look forward to working with the wonderful staff here and our very knowledgeable risk management consultants in serving our valued policyholders. Now let's get on with the webinar. As a Trust policyholder, most of you are likely familiar with our risk management consultation service, the Advocate 800 program. It's one of many benefits our insurers receive through the Trust. 3 of our advocates are with us today, Drs. Julie Jacobs, Dan Taub, and Liesl Bryant. I hope you'll benefit immensely from this risk management roundtable. Please join me in welcoming Drs. Bryant, Jacobs, and Taub.
Thanks so much, John. And we're delighted to be here with you all today. Dan, I'm going to start with you. We do have some topics of a little bit of a heavy nature, as you know, but we get a lot of calls on, managing and working with clients with suicidal ideation. And there does seem to be a slight increase in that. So we want to focus a little on that today, Dan. And I'll start with you about what steps would you recommend that clinicians take to reduce risk when working with clients or patients who present with, say, moderate to high levels of suicidal ideation?
Yeah, good question, Liesl. Just to frame my answer, a brief answer, even if you're very well trained and you get a lot of support and you're using the most effective, well-structured and empirically based treatment, this is very tough work. Our treatments do not save everyone. So we have to be prepared that we will lose patients to suicide, okay? As much as a challenge as it can be, it's really important kind of also as a framework to keep a focus on the alliance, okay? A collaborative approach clearly can reduce risks and can heighten the involvement and commitment of our clients and patients, and also help us kind of manage some of the difficulties. One example, Liesl, is the CamCare suicide status form, and I think Judy's been kind enough to put the link to educational materials on the CamCare website that highlights this phenomenological collaborative approach. Even though I'm saying that we should really focus on the alliance, it's very likely it's going to be tested. So there are times where we have to be willing and ready to step up the intensity of services, either through our own practices or through external supports, referrals. This could include a few different steps: increasing the frequency of sessions, making ourselves more available in times we usually are off, providing resources for 24/7 availability in the community, increasing or having daily check-ins structured, especially to allow the clinician to say, I'm going to call you at a particular time. If you don't pick up, I will call you within, say, 15 or 20 minutes. And if I don't get you, then I'm going to send out the crisis team for a welfare check, that sort of thing. Even though the literature about medications per se is not uniformly positive by any means, referring to providers who can do a medication evaluation is also a very helpful step, as is engaging in means removal counseling. There's actually a fairly consistent research suggesting that when one reduces access to means, the likelihood of suicide goes down, okay? It's also important, if there are close friends, family members, to contact them, if at all possible, and expand the support network if there aren't high conflict or estranged family relationships. So if there are, providing additional supports in the community, for example, DBT skills groups, depression support groups, also a very good idea to help manage risk and to manage the stress of doing this kind of work. Especially important, and I know you hear this from us as risk managers all the time, those of you who are with us today, to consult a lot with knowledgeable colleagues, expert suicidologists, risk managers, other colleagues who are experienced in addressing suicidal behaviors and suicidal ideation. And it's also very important to develop a collaborative safety plan. Now, these are not non-suicide contracts, as you know. The literature typically doesn't support that. But safety plans are a series of steps to help the client, patient have affirmative steps they can take to reduce the likelihood of harm. And one of the questions that comes up in having a safety plan is, what do we do in our outgoing voicemails? Is it okay to just say, call 911 or your nearest emergency room? Well, it's okay to do that, but if we know as the provider, or should know, that the patient is at high risk, it's not enough. We may have to make ourselves available more and be willing to stretch, okay? There's also issues in emergency services for when you're working interjurisdictionally and making sure you can contact directly the emergency services in the other jurisdiction. Some of you have had the experience of calling 911 locally for somebody who's even in a different part of your state, in New York or in California, and they say, "Why are you calling us? That person's in San Francisco, not LA." Okay. And then the last point I want to make is it's very important to document more rather than less of all these steps. And Julie's going to be talking about documentation in more detail.
Yeah, great. Thanks, Dan. You've got a lot of very good information in there in a very succinct way. So thank you. Julie, anything you want to add to that?
I will quickly allude to something that we'll talk more about in a moment, which is your own self-care, right? This is very stressful work. It can be very demanding and very difficult. And so make sure that you're taking care of yourself. And I'm going to go into a lot more detail about that in a moment, but I wanted to make a real explicit tie between working with this kind of population and the importance of self-care.
Yeah, absolutely. Also, because our self-care, as you know, and we all know so well, right, can impact our client care. And I know you're going to say more, so I won't steal your thunder on that. Okay, let's go to the second question then. And, we get a lot of questions on documentation, which this is about. And as you know, we've got people who are in many different settings, hospitals, outpatient, community care, private practice, et cetera. And there's a lot of conflicting messages about what do we have to include, what should we not include, how do we know how much to include in progress notes. So what recommendations would you give for things that clinicians need to consider when thinking about what to include in, say, progress notes?
Yeah, it's such a good question. And I think it comes up so often because there's so little specific guidance on this. The ethics code does talk a little bit about sort of the purposes of records, but it doesn't really go into a lot of detail about the content of records. But the APA does have record keeping guidelines. So it does give us a little bit of guidance. And I know Judith is going to put that in the chat as well. What it talks about is the importance of keeping accurate, current, and pertinent records. So that's something, but it doesn't really tell us much about what needs to be in them. It goes on to talk about keeping records that are appropriate to the circumstances and as required by your jurisdiction. So you need to know what state laws or state regulations might be in place in terms of what should be in your records. It does talking about the nature of the services that you're providing, progress, results of testing, things like that. But again, that doesn't say, what do you put in your note, right? But what the guidance does recognize is that there's going to be different requirements in different settings. An agency may have its own policies and procedures about what needs to be included in notes. Insurance companies have their own requirements. You have to often document the medical necessity of the services that you're providing. Sometimes you have to document the exact start and end times of your sessions. So it's really important to know what contractual obligations you may have, either through the agency that you're working with or an insurance company if you're on a panel. And you also, again, need to know state laws. And a lot of state laws really just sort of circle back to generally accepted standards of the profession. So that takes us back to this APA guidelines and other guidance. Another thing to think about is how are you going to organize your notes? So we have these ideas of SOAP notes and DAP notes. I think those can be helpful ways to organize progress notes. So SOAP notes, it's a subjective, objective assessment and plan. So you're documenting a bit about each of those. DAP stands for data assessment plan. So it's sort of similar information, but having some kind of template can help you organize and make sure that you're addressing each of those issues in your progress notes. Something that I like to think about is what are the audiences of these records, right? Who am I writing the records for? Obviously, for myself as a provider, I want to remember what the heck's going on and know where I can pick up where I left off. And similarly for other providers, either another psychologist or therapist that might step in if something were to happen to me or if we were to transfer care, or medical providers, a physician or a psychiatrist may be taking a look at these records and may need some information. Insurance companies are another audience. So again, if you've got insurance requirements, you've got to make sure that you meet those. A really important audience that we talk about a lot is licensing boards, right? So if you didn't document it, it didn't happen. You've heard that adage. It's because it's true. If you don't document something and the licensing board is looking at a record, they don't know what happens. They don't know what you considered or what you thought about. I'll get into a little more detail about that in just a second, but the last audience is the client themselves, or perhaps their estate after they die. Their personal representative may have a right to access that record. So be sure that you're not documenting things that you would be embarrassed or that you wouldn't want your client to read. Use objective behavioral descriptors, be clear in what's going on, but document in a way that you will expect your client to read it at some point. In terms of level of detail, I'll just touch real quickly on something. Eric Harris has always used this analogy of document like it's ninth grade algebra when we're talking about high-risk situations in particular. So going back to what Dan was talking about, if you're working with a client who's got suicidal ideation or suicidal risk, and you're considering different safety plans or different measures to put in place, document what you're thinking about, document what you do, document what you don't do and why you don't do that. So it may be, for example, that hospitalization is not a good option for a client that you have. Why not? You want the board to know that you considered that option and that you rejected it for a reason, not that you never considered taking that particular step. So you want to make sure that your records are going to tell the story that you want the board to know if something were to come up. And then last, I just want to say quickly about electronic records. You know, those can be great. We've actually got electronic health record templates. There's a link to that in our chats. It also links to record keeping laws in each state, so you can take a look at that. And they can have templates and they can be really useful for you, but don't just copy and paste information into an EHR. You need to actually use the text box and make the note relevant to the specific human being that you're seeing, not just every person with this depression gets the same treatment plan or gets the same note. So that's a super quick overview on a topic I think any of us could talk about for an hour, but hopefully that gives a little bit of guidance and information about what to think about.
Yeah, that was great. You fit a lot in. Dan, anything to add?
Well, actually, I just want to highlight something, Julie, that you said. It is especially important to be gearing our records and expecting that patients will read them now routinely under the Cures Act and the information blocking rule. And so targeting and actually considering the record as an extension of the interventions that we do and having them be honest but compassionate and kind, to me is a very important thing. And it really, in the past few years, this has shifted kind of the level of access has been there, but now it's immediate, particularly, you know, when we're using electronic health record keeping systems that allow an interface with a patient to be able to view them.
Yeah, I agree. And I think that's a great point. You know, the language we use is important, right? We can say a patient's non-compliant with meds, which has a judgmental tone that a client might react to if they read, or we can say client said they're not taking meds as the doctor prescribed, you know, which has a less judgmental tone. So that's a good point. I wanted to also just mention, Julie, this gets to sort of combining what you both talked about, but, you know, in the forensic work I've done a lot of, you know, I talk with attorneys and get to who do a lot of records review. You know, if a client has died by suicide, you know, and the family is seeking some sort of lawsuit, many attorneys that I've talked to have said the first thing they will do is take a look at the record. And on the grounds of, in essence, how good the record is, they will decide whether to move forward or not. So in that regard, you know, records really are, of course, very protective. And if you're writing, like you say, that ninth grade algebra version, that may actually help you avoid lawsuits in the future. So important to keep that in mind. Dan, before I come back to you with a quick question, I just want to comment. I've scanned briefly the Q&As. Definitely go ahead and pop your questions into the Q&A. But there are a couple with just like one word and a question mark. So help us out just a little bit and give us sort of at least as concrete a question as you can. For instance, there's a ChatGPT question and that's it. Well, gosh, we could talk for 6 days on that. So let us know what your actual questions are and we'll be able to address them more specifically. So I just wanted to mention that now so you have time to write that in. And Dan, I'm going to come back to you on the suicide topic. I know there's a lot of ways we could take this, but I wonder if you can talk for a moment about in that very difficult situation where a client does die by suicide, which of course is very challenging and hard. What would you recommend for how clinicians should respond to requests, say, from surviving family members, whether that's requests for information on what happened in the treatment or for the actual record, or even to start doing therapy? You know, how would you help clinicians think about ways to respond to surviving family members?
Sure. So, you know, kind of in my to come an entryway into responding to that question, Liesl, it's important to remember that clients dying by suicide happens to about 25% of us. It is not an uncommon aspect of our work. And although when that happens, it can increase the likelihood of a lawsuit, for psychologists, that likelihood is still, compared to, for example, our physician colleagues or psychiatrist colleagues, pretty low, about 1 in 20 of us. So while it's not extraordinarily high, it's definitely an increase. What one hears at times and reads is, oh, well, you know, you shouldn't respond at all to attempts at contact by the surviving family members. And what I want to emphasize with participants today is that is not our risk management approach. It is not our risk management approach. A core aspect of responding to contacts from family or close friends is to be compassionate and humane, especially perhaps with high conflict relationships. Because I think, as those of you who have had to cope with this kind of experience, not only is the loss of family members by suicide devastating to survivors, it's also devastating to us. So we can extend our compassion and kindness to people who contact us. It is a very important set of steps. It's just a decent thing to do, but from a risk management perspective, it's also a good thing to do. Okay. Now, because it's really hard on us, one of the things that we regularly suggest is that as clinicians, we need a place to grieve, to engage in unedited conversations, but only in a privileged relationship. Talking with the surviving family member about what you think you didn't do right, it's not the place to do that. And not only is that, you know, a self-interested issue, but often it is a natural response when somebody has died by suicide to wonder to oneself, what did I do wrong? What could I have done differently? And the place to do that is in your own therapy or in a privileged relationship, okay? It doesn't mean you shut down how you feel. If you're tearful when you're talking to a family member, that's okay. Expressing your caring for the patient and listening is good risk management and also kind and also genuine if you're having that experience, all of which is important, okay? By the way, you know, although it may technically in many states be legal, even under HIPAA, to disclose information about a patient who has passed away, whether by suicide or another cause, or excuse me, whether it may be legal or not, generally, we encourage you not to disclose that information, except under some fairly narrow circumstances. So not to give specifics out, okay? If you get a request to talk with someone, you can listen. If they ask questions, you can give general information that may be able to help the person on the long road to recovery as a survivor. Folks are often, the people we talk to, you know, in a post-suicide, they often feel angry, guilty. They assume that something they could have done. And hearing you talk about the fact that it is very difficult for anyone else to control what a person will do can be very helpful. But giving referrals for grief counseling to support groups, survivor groups can also be a really useful thing to do when surviving family members contact you. It is very importantly so to refrain from the potential conflict of interest in offering or providing ongoing treatment to surviving family members. Referrals would be appropriate. A meeting or two to talk about what's happened and to be sympathetic, no problem, okay? Now, around the part of the question you asked was, well, what happens if a family member makes a request for a record? Before you go ahead and say sure, make sure that you get a copy of the court order that appoints the person who is asking for the record, whether it's a widow or widower, whether it's a sibling, adult sibling or adult child, whether they've been appointed as the personal representative, administrator, or executor of the estate. This should be a court order, not just the person giving you a death certificate or a power of attorney, which usually lapses on a person's death, okay? So getting a copy of that first. Now, the reason for that is because, unfortunately, often what happens when a person passes away, but especially by suicide, the family conflicts that are happening already get escalated. And so if two siblings are fighting over whether the will is valid because one may have gotten less than the other, then if you don't have the documentation saying you can give one person access over the other, it could cause some real problems for you. So be cautious about it, okay? Also, you can still attempt to try to protect confidentiality by finding out what information the family member wants. If they're willing to accept a summary, great. They say yes, then you can provide a summary. If they say no, then you can still offer to review the record with the person if they are the executor, administrator, or personal representative, and be available to answer questions. In some jurisdictions, you will get a contact by a medical examiner or coroner's office. And again, be careful, because in some jurisdictions, they can get that information without having an authorization from the estate, but in others, they can't. So it's good to ask if you hear from the coroner's office, do you have a written authorization from the personal representative of the estate, the person who's been appointed? If they say, no, but we can do this anyway, ask for a specific section of law that allows access, not the whole probate code, which sometimes they will send us, but specific section. If they send you the whole probate code, you say, this is the whole probate code. That's not what I asked for, okay? Insurance agreements may include requirements for incident reports if something like this, if a death by suicide happens, and they are typically permitted without authorization. But I know, Julie, you're going to talk about this, but I think we're kind of echoing each other because of how important this is. It is so important when you have a client or patient who dies by suicide to really focus on taking care of yourself, addressing your own experience. We are only human, and this kind of experience is frequently very stressful and really causes us to question, okay, and impact us not just at a professional, but also a personal level. Now, the last point I want to make before I stop with this brief intro is the question that comes up about, should I attend the funeral or the memorial? And the response to that is, if it appears appropriate and the family members are not against it, or if they've requested it, it is really okay to do. Remember, what we're trying to do is really let the family know how much we cared. But the challenge can be when a person walks up to you in a memorial and says, well, how did you know so-and-so? So you can use your opaqueness and your skills as therapists by saying, I'm here to pay my respects. Or it's somebody I knew from a while ago, and I just heard about their dying and I wanted to be here. Something that does not give away the nature of your relationship.
Beautiful. Thank you, Dan. Again, you covered a lot of really helpful information there. Julie, anything to add there?
I don't have a lot to add. I mean, again, this is another topic we could talk about forever, but in the interest of time, I am going to leave it at what Dan said. I think he covered a tremendous amount of material there.
Perfect. And we'll definitely get to questions from the audience in just 1 second. Before we do that, Julia, though, I do want to give you a chance to speak to our last sort of starter question here, which is about the importance of self-care, which I know has already come up multiple times. But, you know, oftentimes what we hear from folks is how busy they and we all are, that, you know, we just don't have time for self-care. And I wonder if you can speak for a moment to why it really is important to prioritize that, and maybe some tips on how to do that in a manageable way.
Absolutely. I would say that all of us really consider self-care to be a risk management strategy. It's not an indulgence. It's not, you know, it's not a spa day. It's something that makes us better professionals. If you don't take care of yourself, that can lead to burnout, vicarious trauma, errors in your judgments. It's a legal and it's an ethical obligation, right? I mean, competence is a basic tenet of the work we do. And competence doesn't just include clinical competence, it includes emotional competence. So if you are not emotionally able to do the work, you're not competent, you're not meeting the standard of care, arguably. It can lead to impairment if we're having problems with sleep, if we're abusing substances as a way to cope. It makes us more vulnerable physically and emotionally to stressors and to poor decision making and to judgment lapses. I mean, if we're neglecting ourselves, then it really does impact our thinking and the clarity and the judgment that we bring to the table, which ultimately could harm our clients. The ethics code actually does talk about this. If you look at section 2.06, it's about personal problems and conflicts. And it says that when a psychologist becomes aware of a personal problem that may interfere with their work, they take appropriate measures. That may include professional consultation, and it may include thinking about limiting or suspending or terminating work-related duties, temporarily or permanently, depending on what's going on. And then states also have their own recognition of the importance of self-care, and that comes to play in some mandated reporting obligations. In some states, you have to report another professional who is impaired, who is not meeting the standard of care due to personal problems, substance use, or other issues. So that just shows us that licensing boards do think that it's important for us to not be impaired when we're performing services, be that emotional impairment or otherwise. Self-care is not elaborate. It doesn't have to be a weekend away at a spa. It can be some really simple, not always easy, but simple things like personal self-care, nutrition, sleep, exercise. And we're not talking about running a marathon. Walk for 5 minutes, take a break, get some sunshine, get some air. Attend to your personal relationships, have some fun, go to therapy, draw, write, whatever the case may be. Something that will make you fulfilled, that give you some personal fulfillment. But then there's also professional self-care. We obviously all think that consultation is a really good way to take care of yourself as a professional, right? It's really hard to make these decisions on your own. So consult with us, consult with your peers or your colleagues, connect with colleagues, just talk about, laugh about the stresses of this work. Set boundaries. You know, if you're working from home, if you're in a virtual office or in a virtual practice, when do you stop responding to emails and phone calls? When do you actually have your own personal time? Limit your exposure to traumatic experiences. Don't have an entire caseload of heavily traumatized people if you can avoid it. You need to have a little bit of space for yourself. And just refocus on the rewards. What we do, we are helping professionals. We love to help people, but we can't do that to our own detriment. It's like the old, put on your face your oxygen mask before you put the oxygen mask on the person next to you. If we're not breathing good air and if we're not taking care of ourselves, we really can't be of service to other people in the best way possible.
Beautiful. Thank you, Julie. Dan, any addition before we start taking the live questions?
Yeah, I just, Julie, again, I think you hit it out of the park in terms of you're talking about these issues. One that comes to mind is a study that was done about judges, and that when they were not, that as the day progressed, they got more and more simple in their decision making. And at least a number of authors have suggested that it had to do with their glycogen stores, because right after breaks and eating, they did a lot better and did a lot more complex decision making. So same goes for us. We're not immune.
Yeah, no, I think that's a good point. And not only all the good reasons that Julie mentioned, in terms of reasons for self-care, but also because if we don't take care of ourselves, it can cause real harm to our clients, right? To your point, Dan. So Yeah, it's really important. And certainly we could talk many, many days about that, but we'll see what the questions are and maybe come back to it. So, okay. One, and this is very general, so I'm going to narrow it a little. The question here is, what's the latest with the good faith estimate legislation? Maybe you can just comment, and Dan, I'll let you start with this. Maybe just comment if there's been any significant updates since our last guidance, which is available on the website. But go ahead and I'll let you comment on that.
No.
Well, there you go.
It's just about the same. There's been a lot of storm and drone, but essentially the good faith estimates are the same as they were. The one change already happened in 2022, where there's a different form that the feds are suggesting, but that's been around now for almost 2 years.
Great, thank you. Okay, next question. Do we have to get patients written permission to contact friends or family when a patient is suicidal? Julie, you want to start on that?
I mean, it's the best practice to do so. I mean, obviously, disclosing confidential information is always something we need to do very cautiously. So if you can, as you're creating a safety plan, if you know that a client has suicidal ideation or that's safety risks, as you're creating that safety plan, get them to sign a release of information. That's part of the planning process. Now, there's going to be times when you didn't do that and it feels an emergency and you feel like you are really compelled to reach out and do something. And those are the situations, I hate when we're talking to callers and I say, well, you have a choice between two risky actions, right? You can either not reach out to that person and preserve confidentiality and potentially have that client harm themselves, or you can reach out and breach confidentiality and have to defend your decision to do that. So sometimes it really comes down to which risk is more acceptable to you. If you don't have written permission, then it's questionable whether you can reach out to someone just to discuss a safety plan or suicidal ideation. At the same time, I might be willing to defend that complaint to a board to say that I put this human being's safety first. I recognized that I breached confidentiality. And if you do that, document why you're doing it, right? Here's the 9th grade algebra thing again, right? You maybe can say, we discussed contacting a spouse. We never executed a release of information. I was concerned enough to go ahead and make that contact, understanding that I may not have had appropriate permissions to do that, but I did it out of concern for the safety of the client. So when you can, obviously better to have written authorization. Verbal authorization doesn't do a whole lot for you. You will document it. It will give you a little bit of justification. But sometimes circumstances, sometimes it's a moral question as much as an ethical and legal question. And if you can't sleep at night, if you don't do anything, then you bear the risk of having to defend a complaint or an allegation of breaching confidentiality. And you explain that your justification was to try to keep this person safe.
Mm-hmm. Yeah, very good points. Dan, any addition there?
No, I think she's right. I think, Julie, you're right about that.
Yeah, I agree. And just to add clarity, I think one of the things that you sort of said there is that it depends also on the degree of suicide, what we call suicidal, right? If someone's just having what we might call passive suicidality, then you of course, you're not going to breach in that regard. But if you're really worried and there's imminence and you're very concerned, I think that sort of bumps it up to that level. And of course, as we always say, consult. If you have time, if it's a true emergency and you don't have time, then you just act just as Julie said, and you maintain safety. So great. Okay, next question, and Dan, I'll send this one your way. It says, I've had the unfortunate experience of picking up patients who had been seen by a clinician who himself died by suicide. Mm-hmm. I made them aware of his death. He had a pre-existing illness of which they were aware. They assumed this illness killed him. Any thoughts, Dan?
Great question. It's really tragic. I think in terms of working with the survivors, in this case, the patients who are survivors, I think the focus, again, is going to be on building alliance and trust. Often when a person dies by suicide, those who survive experience it as a very, very intense, aggressive act. And so trust can be undermined with future providers, even though I think from internal experience for a person who ends their lives, it's an act of desperation and a very, very narrowed view of options. But I think helping clients or patients understand that that's likely the motivation, that understand if they feel that it's directed towards them, that it's not, that this is about the person themselves, much like we do with surviving family members. I also think that we have to use our judgment, as often is the case here, about how much we disclose. If we know more about the colleague, and it may be helpful, and we don't think the colleague would object or would have objected to our disclosing, okay. Had a similar experience to the questioner, and it was very clear that the family of the colleague did not want anyone to know any details. And so that limited what I would and could say.
Great answer. Great. Julie, anything to add there before I?
No, I think it's a tough situation, and it's also, it reflects on us. So we have to be sure that we're our own reactions. If it was someone we knew and a colleague that we were close to, that we don't let our interactions or our reactions to that interfere with our ability to help the client. So just always having that self-awareness of your own emotional competence and ability to work with that specific situation.
Yeah. And again, having that low threshold for consulting. I mean, this is something we don't get calls specific to a clinician having died by suicide, but we do get a lot of calls about, hey, a clinician died, and it's my task to sort of help, notify patients and those kinds of things. So that's a great time to get some good consultation. I'm going to ask one more suicide question here, and then we're going to go on to a couple of more random topics. But this one says, do you need to specifically ask about suicide each session if it's not something of significance? AKA no history, no increased symptoms, no indication. Dan?
Basically, you use your judgment about whether there seems to be increased risk, increased agitation or distress. That's when you would ask again. But for someone with no history, you do an initial screening and there's nothing there. It's not as if we always have to ask every time. That being said, and this relates, Julie, to what you were saying about documentation, it is a very wise practice each time you have start a session to find your own way to ask, are there any crises or things happening that are really distressing for you? Because that can help surface without narrowing it in on suicidal ideation or homicidal ideation or an awful lot of distress because the loss of a partner. Usually our clients will tell us, but it's very important to document that you've asked, because if it later happens, and actually I've seen a couple of cases like this where a patient or client dies by suicide and it's just unexpected. The clinicians didn't expect it, family didn't expect it. And the question's going to become, well, did you check in? Did you ask them what was going on? And that brief question in your notes or in the structure of an EHR that says any crises or emergencies, and you respond when asked, none reported, that's gold for us in terms of protecting ourselves. But it's also clinical gold, because when we ask those questions, folks know we're interested. And most of you know, when we don't ask about substance use, people don't tell us. But the data suggests that a very large proportion of the psychotherapy patients we're seeing are using substances, often to excess, and they never tell us unless we ask them. Same idea.
Great points, Dan. Julie, I'm going to send the next one your way. This is changing topics, but a little bit related to records. So what about concerns that are arising around movements in many states for the HIEs, or the health information exchanges, and what happens to those notes and records?
I don't have a whole lot to offer on that, and I may have to ask for some help. I mean, I think anytime there's going to be any interchange or interoperability with records and protected health information, we need to be really on top of who's going to have access to that and under what conditions. And so if states, I know that some states are creating these exchanges. Some of them, I think, have allowed certain providers to opt out so that mental health information is not something that necessarily needs to be included. But we are in a digital world. It is changing so fast, and there are so many new demands. I know that my state is talking about implementing some sort of exchange of that nature, and I immediately brought up concerns. How are we going to contain this? What are the boundaries going to be? What are the rules going to be? And so being aware of exactly what the authority is, what should be shared, what exemptions are possible. And if it's something that's starting to pop up in your state, you can advocate, right? I am a big advocate of advocacy. Being involved in your state association, those are the folks who know what's going on. And if there is some concerning legislation coming up, a whole bunch of psychologists and mental health providers providing comments and testimony and emails to their representatives can be extremely powerful. So I think as we are in this very changing and emerging dynamic environment, we need to stay on top of what's going on, and we have the ability to prevent things from happening that shouldn't be happening. So staying abreast of that, being a part of your state association, getting those alerts that come out, and just knowing what's happening can help us figure out how to navigate some of these more interesting and emerging technologies that are occurring.
Great. I think that's great. Dan, any quick additions there?
Yeah, just to give an example of how advocacy helps, there's at least a couple of states I'm aware of where they had initially proposed just everything. If you have an electronic health record keeping system, you would have to share everything if you're engaged in doing any kind of insurance or even without insurance. And with pushback by coalitions of healthcare and mental health care professionals, it got narrowed to not, at least in one state, to not include mental health records unless the client opted in. But so there are alternatives. These health information exchanges are creatures of our electronic, as you were pointing out, Julie, our digital world. And it's very important to know what your state requires. And if it's requiring things that you don't believe are appropriate, to really be politically active, because it needs to change at a legislative level. An individual level is not going to make a difference.
Yes, and not to complicate it further, but I guess to complicate it a little bit further, if you are practicing in other jurisdictions, you need to be aware of any requirements, in those jurisdictions that you may also have to abide by. So this is another one of those unique things when we're doing interjurisdictional practice that you need to be on top of as well. So, okay, let's see. I'm going to start skipping around a bit in some of these questions, but here's a question about how do you contact the local police departments or emergency services for clients that you see via SIPACT? What would you recommend? And in this case, why don't we broaden it, not just SIPACT, but any, when you're crossing jurisdictions, either to another state, say in the US, or as we know, which is more complicated sometimes if you're doing international telehealth and working with someone overseas. Julie, do you want to start with that one?
Yeah, I think it's a basic standard of care when you're doing remote work that you create a crisis plan at the outset, even if it's not a client who you expect to be in crisis. You need to know what resources are available. You need to know where the client's going to be during the provision of your sessions so that you can reach out to the closest and most appropriate resource. So I would actually suggest, as part of the intake process, if you're doing virtual work, where are you going to be during the sessions and what resources are available? Is there a mobile crisis unit? What is the phone number for that? What is the closest ER? Whatever the case may be. And then ask at the beginning of each session where they are. And I get some pushback on this from people. It's just not something I do. It's not natural. It doesn't feel good. Well, okay, it takes all of 10 seconds to say, are you at the address that you indicated on our intake paperwork? If not, where are you? Because you don't know if something might happen, not just a mental health crisis. What if there's an emergency of some kind and you have no idea where the person is? So it really is, it's a standard of practice for a reason, because something can happen. So when I think about an informed consent for teletherapy, I think an element of that should be, where do you plan to be during our sessions? Obviously, there's going to be times when they're in a different location. And then identifying at the outset, what resource would you reach out to if there were a crisis, so that you're not scrambling and trying to do a Google search or figure out where that is. You just look to the record and you are able to respond quickly. Yes, it's a little bit of a hassle, but we don't know. I don't know what the resources in Utah are. I'm in Colorado, so I need to inform myself. And if you're not able or willing to do that, then you ought not be practicing into other jurisdictions. Stick to what you know and stick to the resources you know. It's really, it doesn't matter until it matters, and then it matters a lot.
No, great point. And to your comment on getting the address, I think once you get in the habit, it can feel uncomfortable initially, but once you get in the habit, you can actually, in a way, train our clients to where they'll come to session saying, hey doc, I'm in a new place, or I'll be in another place next week. And so it just becomes part of the rhythm of the treatment. And as you said, very important standard of care there. Dan, I'm going to hand this next one to you because there's been different versions of this question, and I know you sort of said it, but sometimes I think it's very helpful to repeat things to be really clear. So the question here, I've always heard that acknowledging someone was a patient without consent is not okay, even after a patient passes away. So how do we respond to a surviving family or friends with this in mind?
Mm-hmm. Well, a strict interpretation would be that we say nothing. And as I mentioned earlier, from a risk management perspective, acknowledging and listening is a probably both a more kind and compassionate approach. And also, you don't have to give away much at all. Okay, so yes, confidentiality survives when a person passes away, at least, from an ethical perspective. In some states, the law says that, there are more limitations. But I understand the conflict here. I think our perspective, and Julie, Liesl, you tell me if you think I'm off here, but our perspective as risk managers is they know we're the treating professional. They're getting in touch. If we do a stonewall, the much more likely response is, what does Dr. Dan have to hide? Did he do something wrong? But even worse, did I do something wrong? That is the family member. So listening, brief acknowledgement, it's probably very low risk. The likelihood of the executor of the estate or the surviving spouse getting upset if you listen and give general information is not very high.
Yeah, no, I love that, Dan. I mean, I think Julie and I both definitely agree. And I think you've highlighted there the importance of a true risk management approach rather than sort of a cookie cutter in situation A, you always do B. You handle it, differently, obviously keeping in mind the risks, but yeah, it's a little more nuanced. So thank you for clarifying that. Julie, I'll send this one your way. It says here, a client seen in telehealth starts to contemplate suicide, and I feel they need to be seen face to face, but it's not feasible to meet in person with me. How do I make a referral without abandoning the client?
That's a great question. This is sort of the warm handoff that we talk about, right? So you could even, there's lots of things you can do to make sure that there's not a gap in care. I mean, you could be on a virtual session with someone and set up an appointment with the provider, or you could see if they could have an in-person session and invite you to that, to make that introduction and to make that connection. But what you want to do is make sure that they do get some sort of warm handoff. And it may not be forever. It may just be for this crisis period. But it's really important to make an actual connection. So that's where knowing where they are and knowing what the local resources are can be really important. But it's not enough to just say, hey, okay, now you need to talk to someone in your own state and here's a couple names. I think these are the situations where we go a little above and beyond what normally would be our obligations to actually connect someone to that provider. Again, maybe we're on the phone together and make an appointment. We get a release of information and we provide some information to the new provider and consult with them and give them a little bit of background. But you can't let that person just fall away because you're not able to be there physically. There's got to be some sort of actual handoff, and that they are in the hands of someone else, at least temporarily, and that in-person provider can sort of take the steps that they need to stabilize that person. Maybe they take it from there, or maybe they want to come back to you once that crisis has been averted or addressed. But it's not a situation where, we respect client autonomy and we give them the right to make choices about care. But if we have someone who's in an acute safety situation, we really need to go a little bit above and beyond and make sure that we've made that connection very explicitly, and that we know that we have some level of confirmation that they have actually made an appointment and shown up and talked to this person, so that we can kind of let go a little bit of our own sense of obligation there.
Great. Dan, any addition there?
No, I don't.
Great. All right. Well, then I'll hand the next question to you.
Okay.
Working with patients in an outpatient setting has certain limitations related to reducing access to means or having patients see a psychiatrist, say, for a med eval, unlike in an inpatient setting. So how do you recommend, and here not clinically, of course, there may be some clinical, but more the risk management perspective of how do you navigate concerns related to suicidal or self-injurious behaviors with patients struggling with either the inability or unwillingness to follow recommendations like, reducing access to means and getting med evals, those kinds of things.
Yeah. Well, these are all kind of I think of them as a series of potential risk management steps. But just because you can't do one or two doesn't mean you can't work with the person. So if for now my client refuses to get medication, and I know they've had a bad experience before, they've talked about it when being on a previous med, I don't necessarily have to force them, but I want to document that I've suggested it and that they've declined. And this is much like what you were talking about, Julie, around, whether you can contact a person who we don't have permission to contact. Really, if it gets significantly more intense, then we may move towards the person doesn't have a choice about this. We get them involuntarily treated. But means removal, for example, we will not remove means for a client. It's a traditional risk management ideas. If the client comes in with their firearm and they say, "Here, Dan, take this firearm from me so I don't hurt myself," I am not going to take that firearm. What I'm going to do is I'm going to counsel them about how to have that less accessible. So our work is to help them think about how they can put barriers between themselves and a weapon during a period of high acuity. Okay. But if they refuse that, we make judgments about, are there other steps we can take? For example, safety planning. Are they willing to agree? If it gets more and more to the point where the person is unwilling to agree to a safety plan, commit to treatment, won't work around, means restriction, refuses referrals, that's probably not a person we should be working with outpatient in that kind of crisis. They're at a higher level of acuity, and then referrals would be necessary. The thing that the issues that Julie was just talking about in terms of not abandoning somebody, we can't simply say, well, forget it, but we also can set limits. We can set conditions for the services we're providing, saying, if we're going to work together on an outpatient basis, I'm going to need to have your agreement that I can contact your psychiatrist, or you will allow me to, and will work with me on a safety plan, will respond to questions. If that's not something you can agree with, then we're going to have to work towards transfer of care. And if it's really an emergency, then that transfer of care hopefully won't be, but may be against that person's will.
Right, great points, thank you. I am noticing our time. I'm going to try to fit in two of these last questions here related to self-care, because we haven't followed up a lot on that. So one question here is, this is someone who recently experienced a death, very close family member death, and they say that they're fine with some clients, but not other. This is a clinician returning back to work with patients, but it's still a struggle with other clients that require a lot of mental energy. Is it okay to re-enter practice with low stress clients? So Julie, can you maybe speak to how do we re-enter? How do we know what makes sense, that kind of thing?
Yeah, I love this question because it reflects a lot of self-awareness. And I think that sometimes we don't give ourselves the grace that we give to our clients, and that we think that it's all or nothing. I can either do this work or I can't. And we might try to gut through clients that are just more than we can manage. So we do need to recognize our own limits. That's part of self-care. And so if it's too much for you to have all of your high stress or high needs clients right away, then you make sure that they're taken care of, but it doesn't have to be by you. So I think it's okay to tip your toes in the water a little bit more gently, to not necessarily dive in head first, but to recognize that, I'm going to restart my practice with a small number of clients who are relatively stable, who are going to give me the opportunity to exercise those muscles again and to get used to the rhythm of clinical practice, and to be aware of your own limits. And it may be that you think you can manage it and you can't, and that's okay. At that point, you just give yourself permission to back away. And again, we're not abandoning folks, but giving somebody a referral temporarily while we get our own house in order is okay. Document what you're doing, document why you're doing it. But working yourself to a point where you're going to break is helping nobody and is potentially harming you and a lot of your clients. So you want to do it in a mindful way. There's no reason, it's not all or nothing, okay? That we should not fall victim to the black and white thinking. You can start slowly and test the waters and make sure that you're really able to provide the services that you're trying to provide.
Yeah, great. I really do agree. And just to add on to that, you said giving that referral to others is okay. I would actually add, not only is it okay, but that in many ways is how you serve the best interest of your client in those situations. So when we are not able to be our full selves and the best clinician we can be, giving a referral while we, as you say, get our own emotional house in order, or get better and tend our own needs, giving that referral is how we take care of our clients.
And it models that for the clients as well. So
Yeah.
that's a good example to set for.
Yeah, beautiful on all those. All right, so the last question, I think, unless it goes super fast, we'll see. But Dan, I'll send this one to you. It's also on self-care. It says, you're describing self-care that often we are unable to do because of the restrictions placed upon us by our organizations. While self-care is important, so is remaining employed and being able to take care of our families, I presume financially. Many of us can't make shifts at a drop of a hat. How are we able to combat the systemic issues that prevent us from engaging in healthy self-care? Or is this a lost cause?
I don't believe this is a lost cause, and I'm trying to keep this really short because, John, I see that we're just about done. But I think that if you have a union and you're in an organization, you can push to create more space for clinicians to take care of themselves. I also think some of the habits that Julie was talking about, if you're meeting with your colleagues, even for 10 minutes after the day is done, to talk about what's happened, to support one another, to make sure you're eating okay, all of those things add up. So I actually think it's the opposite of a lost cause. And having worked in large organizations that are incredibly demanding, and I'm not referring here to the trust because we have this is a great environment, very supportive environment. I do believe that you can create change, and that you do that if you work with other folks, if you pay attention to what you need, and also if you do the small things. I would start with the small things. Yeah.
Yeah, and I'll add on that, I really believe that self-care is in many ways, yes, there's all the big things that we need to do, of course, but it's also a moment by moment choice, right? When you can make a choice in this moment that will benefit you in terms of down regulating and lowering stress versus a choice that's going to increase that stress. Sometimes it's as simple as standing up, going outside for 3 minutes and sipping some water as you deep breathe. I know that can sound small, and yet sometimes it's the smallest of choices that can make a very large impact. And I know, Dan, I'm sorry, John, we are right at time, so I'm going to turn it back to you. Thank you.
Okay, what another great roundtable. Thank you, Drs. Bryant, Jacobs, and Taub, for taking the time to be with us today and sharing your knowledge.